fracture and its complication. Now, high risk of ankylosis. The chances of ankylosis is very high if the percentage is less. If it is less than 5 years, the chances of TMJ ankylosis is high. And the problem with TMJ ankylosis is it can't be identified immediately after the trauma. Okay, there will be TMJ ankylosis. It will take few years to undergo ankylosis. After that, during the growth of the patients, maybe after 10 to 15 years, there will be severe asymmetry and mouth opening will be nil. Okay, at that moment, you have to do the major surgery. You have to do TMJ ankylosis release the ankylotic chunk. You have to replace the temporomandibular joint. Okay, along with you have to do distraction osteogenesis in order to compensate the growth on the contralateral side, as well as in order to relieve the obstructive sleep apnea, as well as then you have to go for orthognathic surgery. Now, the chances of ankylosis is high if the patient first criteria is if the age of the patient is less. If it is pediatric patient, the chances is very high if the patient age is less than 5 years. Though we consider patient as a pediatric if the patient age is less than 12 years. Okay, above 12 years, we consider it as an adult and we treat accordingly. Another criteria is intracapsular fracture. The chances of ankylosis is there if the condylar head is fractured, if the fracture is present within the TMJ capsule. Right. The next criteria is torn meniscus. It is not that whenever the condyle is fractured, it will go into TMJ ankylosis. Certain criteria has to be met. Next criteria is torn meniscus. Meniscus is articular disc. If the articular disc is ruptured and if the condylar stump is in direct contact with the temporal bone, then the chances of TMJ ankylosis is high. Then possible damage to glenoid fossa. Glenoid fossa is a part of temporal bone. Proximity of a stump to glenoid fossa. The ramal stump has to be in contact with the temporal bone in the glenoid fossa and associated zygoma and coronal fracture. Associated zygoma and coronal fracture is a different thing. It is not a TMJ ankylosis, though the mouth opening will be nil. The above 5 criteria has to be met for TMJ ankylosis. So TMJ ankylosis to happen, there should be patient age should be less than most commonly 5 years of age. Then intracapsular fracture, it has to be condylar head fracture, intracapsular fracture. The articular disc has to be torn. Then possible damage to glenoid fossa, and the ramal stump should be in contact with temporal bone. It is not like that whenever there is a condylar fracture, it will go into TMJ ankylosis. Okay. The fracture part has to be in contact with the temporal bone. As we know, in case of temporomandibular joint, the articular disc divides the joint compartment in 2 parts: superior compartment, inferior compartment. The articular disc has to be teared. Then the ramal stump has to be in contact with temporal bone. Next is associated zygoma and coronate fracture. What happens sometimes, even though the TMJ is not fractured, but when the coronate process and zygomatic ZMC is fractured, zygomatic arch is fractured, in such cases, during the healing phase, the coronate process may fuse with the zygomatic bone or zygomatic arch. So in such cases also, the patient could not open the mouth. Patient mouth opening will be nil. It is also considered as false ankylosis. It is not a true ankylosis. It is false ankylosis, though the TMJ is normal, but patient could not open the mouth because the coronate process is fused with zygomatic arch. During the healing phase, coronate process may fuse with the zygomatic arch or zygomatic bone. Now, the treatment of TMJ ankylosis, there are various modalities of TMJ ankylosis treatment, and it has been asked many times. So the problem with TMJ ankylosis is, even though we release the ankylotic chunk, the mouth opening will be there, but the problem is if the joint is not there, the proper mouth opening will not be there. And also, if there is a bilateral TMJ ankylosis, it will lead to anterior open bite. So we have to create temporomandibular joint. In case of adult patient, the best treatment is alloplastic. We say it as alloplastic TMJ replacement. We have to put artificial temporomandibular joint. There is condyle, which is made of titanium, and we also have fossa. So we have to attach the condylar part in the ramus of the mandible and the fossa in the temporal bone. Okay, so we have to create a new joint. Alloplastic TMJ replacement is not done commonly. It is very common in India and other part of the world, but in Nepal, rarely it is done. We are planning one case. Most probably within this month, we will do one TMJ replacement here in Kathmandu. There is one case of osteochondroma in the condyle. We have to do condylectomy and then we'll replace the TM joint. Also, there is another case of osteoarthritis. Both the TMJ is gone. There is flat surface and mouth opening is nil in that patient. We'll consider again it after few months. So the best treatment in case of adult patient is release of ankylotic chunk and replace the ankylotic chunk with alloplastic TMJ. Alloplastic, we have to put artificial temporomandibular joint. Otherwise, patient could not function. When releasing the temporomandibular chunk is not sufficient treatment. You have to do rehabilitation as well. So you have to release the ankylotic chunk. I think you might have studied the Cowans protocol. Have you heard or not? In case of TMJ ankylosis, what is Cowans protocol? You have to release the ankylotic chunk. The gap within the joint area should be a minimum 1.5 centimeter. You have to do rehabilitation with either rib graft or a sternoclavicular joint. In order to prevent the recurrence, you have to put either temporalis fascia or buccal fat pad. So during the treatment of TMJ ankylosis, in case of adult patient, after releasing the ankylotic chunk, you have to replace the temporomandibular joint with artificial joint. We call it as alloplastic TMJ replacement or alloplastic TMJ. Again, the temporomandibular joint is artificial TMJ is of two types. One we call as a stock joint, another is custom fitted. A stock joint is a ready-made joint, so it is available in a small size, medium size, and large size. In Nepal and India, most commonly we use a small size because the size of the patient ramus is less as compared to the Western country, and most of this stock joint is made in Switzerland and other country. So we have to import that. So that is a stock joint. The problem with the stock joint is the stock joint may not fit in every patient. Okay, so there might be some gap within the ramus. Another variant is we called as custom made. Custom made is we have to do that NCCT phase CT scan. Then we send the CT scan to the company. Then they will make the artificial TMJ for that patient. They will send back that is made of titanium, and then we have to place that custom made joint to the patient. It is more better. We are planning for this custom made joint, and it is made in Delhi IIT, Indian Institute of Technology. So we have to send them CT scan. CT scan cord should be less than 1 mm. Ideally, it should be 0.625. Then they will make the temporomandibular joint. They will send it back to us. Then we'll fit it to the patient. Will do condylectomy and we'll fit the condylar part to the ramus and the fossa part to the temporal bone and the TMJ. And we have to replace the normal TM joint with an artificial temporomandibular joint. So basically, in the case of adult patient, if you are releasing the ankylosis, or if there is any problem in the joint, like either it may be ankylosis, it may be osteoarthritis, it may be trauma. Sometimes due to trauma also there is comminuted fracture of the condyle, then you have to replace the whole of the condyle. In such cases, in adult patients, if the patient age is more than, let's say, 17-18 years, the growth phase has been completed, then in such cases we have to replace the TM joint with alloplastic TMJ. Alloplastic TMJ again is of two types. One is a stock joint, another is custom made. Custom made is for a specific patient, that is more accurate. Another is a stock joint. A stock joint can be placed in any patient, but the problem is it may not fit properly in all the patients. Okay. Now this is for adult patient. The problem is pediatric patient. As you know, TMJ ankylosis is more common in pediatric patient. What will you do in case of pediatric patient? Let's say patient has a TMJ ankylosis and the age is about 11 or 12 years old. Then what will you do? You can't put alloplastic TMJ in such patient because patient is still in growth phase. If you put alloplastic TMJ in such patient, the patient will grow, and after a few years it will not fit because the size of the mandible will grow, size of the cranium will grow. So alloplastic TMJ is not indicated if the patient is in growing phase. And we have to release the ankylotic chunk because the patient mouth opening is nil. He or she can't eat, can't drink, can't speak. We have to address that. What we have to do in such pediatric patients is we have to release the ankylotic chunk. Then we have to do rehabilitation of temporomandibular joint. And most commonly, what we do is after releasing the ankylotic chunk, we place the rib graft. Commonly, we say CCG, costochondral graft. And preferably, we prefer 5th or 6th rib for costochondral graft. It is commonly asked which rib is preferred for TMJ ankylosis rehabilitation in pediatric. It is 5th or 6th. From the 5th or 6th rib, we take the costochondral graft. It's not a rib graft; it's costochondral graft. Why say it as a costochondral graft? Because as you know, in the sternum, when the rib connects with the sternum, there is some cartilage. So, for rehabilitation, we have to put some cartilage as well, because the patient is in growing phase. Once the mandible is driven forward by the soft tissue matrix, then the condyle has to grow as well. And for the condyle to grow, if you put a bone will not grow. So we have to put cartilage. That's why we prefer costochondral graft. In case of costochondral graft, we take rib as well as adjacent cartilage from the medial surfaces. Another important thing in this is the thickness of this cartilage should be 2 to 4 mm, not more than that. If the size of the cartilage is more than 4 mm, it will break. If the size of cartilage is less than 2 mm, the cartilage will not grow. So size should be specific. I'm talking only the cartilage cap, not the whole graft. The size of the graft is about 5 to 6 centimeters, because it has to be attached at the lateral surface of the ramus, and it has to be extended till the temporal bone. The size of the rib graft is about 5 to 6 centimeters, depending on the size of the patient. But the size of the cartilage or size of the cartilage cap which is present in the rib in case of costochondral graft is about 2 to 4 mm. It must be a specific. If it is more than 4 mm, it will break. If it is less than 2 mm, the cartilage or bone will not be found. The first treatment in case of TMJ ankylosis is, first line of treatment in pediatric patients is for rehabilitation. We can use costochondral graft, CCG, in case of pediatric patient for rehabilitation. And it is taken from either 5th or 6th rib. Again, it has some significance. Why 5th or 6th rib? Because the muscles attached in that area is attached to the superior surface. The muscles which is present above the 6th rib is attached above the 6th rib, and which is present below the 6th rib is attached at the inferior border of the rib. So it's easy to take the 6th or 5th rib. Another thing is you have to know is always we prefer costochondral graft from the right side, never from the left side, because if there is some pain, then you can't distinguish whether it is cardiac pain or due to the pain of costochondral graft. So in order to avoid this confusion, we prefer costochondral graft taking from the right side, 5th or 6th rib. Because the muscles which is attached in that area is, suppose let's say if it is a 5th or 6th, let's say 6th rib, the muscles which attach superior, the surface is attached to the superior border. Okay, the muscles is inserted in the superior surface in the above the 6th rib, and other muscles is attached is present just below the 6th rib. So it's better to give incision in that area, because you don't have to cut the muscles. If you cut the muscles, the problem is there will be profuse bleeding. For our convenience, we prefer 6th rib. Some patients it is present in the 6th rib. In some patients it is present in the 5th rib. It varies. First option is costochondral graft for TMJ ankylosis rehabilitation in pediatric patient. Now, second option can be sternoclavicular joint. Sternoclavicular joint can also be used for rehabilitation of temporomandibular joint in case of pediatric patient in TMJ ankylosis case. Though it is less preferred, it is done in some center in India. Third option is you can take metatarsal joint as well, though it is less preferred. Another thing you have to know in case of ankylosis is the chances of re-ankylosis is very high, because even though you remove the chunk, and as you know the nature of the bone, it always tends to heal by itself. So the chances of re-ankylosis high if the bone is again found in the joint area. In order to prevent the re-ankylosis, you have to put some either alloplastic material or temporoparietal fascia or temporalis muscle, so that it will separate the condylar part and fossa part. It will separate the ramal bone and the temporal bone. There should not be any contact between the temporal bone and the normal ramal stump. In normal cases, what happens? The articular disc separates the condyle and temporal bone. But in case of TMJ ankylosis, articular disc is already gone. There is complete fusion of the temporal bone with the condyle. So in such cases, in order to prevent the TMJ ankylosis, you have to put some structure between the two bones so that the re-ankylosis will not happen. And the most commonly, we prefer buccal fat pad, because the buccal fat pad is present just adjacent to the TMJ area. So you can put a buccal fat pad within the TM joint after whether it is it doesn't matter whether it is pediatric patient or adult patient, whether you replace the TM joint with alloplastic TMJ, artificial temporomandibular joint, or costochondral graft, you have to put buccal fat pad in order to prevent recurrence. If you put the buccal fat in that area, what the buccal fat will do, it will fulfill all the gap which is present within the joint, and it will not allow new bone to form, and the chances of re-ankylosis is low. The first option is, in order to prevent the re-ankylosis, you can put buccal fat pad. The second option, you can also put abdominal fat pad. Abdominal fat pad is taken from the interior part of the abdomen, just below the umbilical cord. The transverse incision is given, and you can take the fat from the subcutaneous area. So abdominal fat pad can also be placed in the TMJ area in order to prevent the recurrence. Traditionally, temporalis fascia was also taken. Nowadays, it is not preferred, though you must know temporalis fascia can also be used in case of treatment of TMJ ankylosis in order to prevent the recurrence, because the temporalis fascia will also create a barrier. It will not allow the ramal stump to contact with the temporal bone. The idea is temporal bone should not be in contact with the ramal stump, so that the new bone will not be formed and there will not be re-ankylosis. The third option is again temporalis fascia. The fourth option is temporalis muscle. You can incise the temporalis muscle and you can put that muscle within the temporomandibular joint, so that it will create a barrier between the ramal stump and the temporal bone, so that the bone will not form. Slide display भएको छैन. अर्कोमा डिस्प्ले भएको छ कि छैन? स्लाइड देखिरहेछ तपाईहरुमा?
देखा छैन सर.
छैन? हजुर. नेपालीमा भन्दाखेरि फेरि अरूले बुझ्नुहुन्न. स्लाइड कसैकोमा देखिएको छ कसैमा देखिएको छैन भने तपाईहरुकै यहाँबाट प्रब्लम भएको भए त कसैकोमा पनि नदेखिनु पर्ने.
Sir, there is only one slide on the screen. High risk of ankylosis only.
Okay, we are talking about ankylosis. Ankylosis को treatment basically adult patient र pediatric patient मा दुईटा फरक हुन्छ. Adult patient को केसमा चाहिँ growth phase complete भइसकेको हुनाले गर्दाखेरि you have to replace the TMJ ankylotic part with the alloplastic TMJ, artificial TMJ राखेर replace गर्न सक्छौं. Adult केसमा दुईटा अप्सन छ alloplastic TMJ, artificial TMJ राख्नको लागि. Either you have to place stock joint or custom made joint. Custom made joint उनको स्पेसिफिक पेशेन्टको लागि स्पेशल त्यही पेशेन्टको लागि बनेर TM joint आउँछ भने stock joint भनेको यो चाहिँ तीनटा भेरिएन्ट पाउँछ, स्मल मिडियम र लार्ज भेरिएन्ट. युजुअली हाम्रो एशियन पपुलेसनमा स्मल भेरिएन्ट स्मल साइज युज गर्छौं. चेन्ज गरेकै छैन, यहाँ चेन्ज भइरा छैन भनेर मेसेज गर्नुको. स्लाइड चेन्ज भएको छैन, अहिले फर्स्ट स्लाइड नै चलिरहेछ. So in case of adult patient, we have a stock joint in three sizes: small size, medium size, and large size. In Asian population, in most of the cases we use only a small size because the size of the ramus is small. In case of And another option is we can use a custom made joint. Custom made joint is made for specific for certain patient. We have to send the CT scan to the company. The company will depending on the anatomy of the ramus and condyle, they will make the new joint for the specific patient. We can't use that joint to any other patient. So custom made, custom fitted joint can be placed in case of adult patient. So in adult patient, we have two options. Either we can use a stock joint or custom fitted joint or custom made joint. Custom made joint is preferred. And fortunately, we are also starting this treatment in Nepal soon. In case of pediatric patient, again, we can't put alloplastic TMJ because the patient is in growing phase. So in case of growing phase, you can't put an alloplastic TMJ replace TM joint. And another thing you must understand is in case of growing patient, you must not do any orthognathic surgery in this stage. You have to wait for at least 18 to 19 years. When the growth phase is completed, then only you can proceed for orthognathic surgery. Because if you do the orthognathic surgery before that age, patient is in growing phase, again everything will be gone. Because if the size of the bone is increased, there will not be any proper function. The occlusion will be gone. So you have to wait at least for 18 to 19 years. Once the growth phase is completed, then you can proceed with orthognathic surgery. And in these cases, in TMJ and callosis case, patients you have to do orthognathic surgery as well, because there is severe facial asymmetry. Now in pediatric patient, you have to do TMJ ankylotic chunk release, along with you have to do the rehabilitation. Rehabilitation can be done with costochondral graft, CCG. Preferred is 5th or 6th rib. You have to take the rib graft from the costochondral junction near the sternum. The size of the cartilage cap should be 2 to 4 mm. If it is more than 4 mm, it will break. If it is less than 2 mm, the bone will not be formed. Endochondral bone formation will not take place. Another option can be sternoclavicular joint. The tarsal joint can also be taken, but only for theory purpose. You know that practically in most of the cases we use costochondral graft. In order to prevent the TMJ ankylosis, both in case of adult patient and pediatric patient, most commonly use buccal fat pad. It will prevent reunion of temporal bone with ramal stump. So most commonly used buccal fat pad. The volume of the buccal fat pad is just 10 ml. It is present adjacent to the temporomandibular joint. The advantage of buccal fat pad is its pedicle flap. The blood supply is intact. As the blood supply is intact, the chances of resorption of buccal fat is very less. That's why it is preferred more. Pedicle flap means blood supply is intact. Next option is you can also take abdominal fat pad. It is not a pedicle flap, so chances of resorption is high. We can also place a abdominal fat pad if you can't find a buccal fat pad or if the buccal fat pad is less. दुब्लो पातलो मान्छेमा गालामा adipose tissue sufficient छैन, buccal fat pad छैन भने त्यति बेला चाहिँ you have to go for buccal fat pad. In case of thin and lean patient, you may not find sufficient amount of buccal fat in cheek area. So in that case, you have to go for abdominal fat. So second option is abdominal fat pad. Third option is you can use temporalis fascia. Temporalis fascia is placed between the ramal stump and the temporal bone. It will also prevent the re-ankylosis or recurrence. Fourth option is you can put temporalis muscle. Temporalis muscle is incised and it is placed between the ramal stump and the temporal bone. Fifth option is you can put any alloplastic material. Usually it is made up of rubber. Usually it is silicone material. It is soft, and its function is just to prevent the formation of new bone. It will prevent reunion of ramal stump with temporal bone. So theoretically, you must understand all the 4-5 options, but practically in most of the cases we use buccal fat pad, both in case of pediatric patient as well as in adult patient. Even in case of adult patient, we replace the joint with alloplastic TMJ, artificial temporomandibular joint. The chances of recurrence is still there because the extra bone may form adjacent to the artificial temporomandibular joint. In order to prevent that recurrence, you must place buccal fat pad around the artificial temporomandibular joint, so that the recurrence will not happen and the chances of re-ankylosis is decreased. In order to treat the ankylosis, you have to approach through the pre-auricular approach. Incision is given just anterior to the external ear, just adjacent to the anterior to the pinna, just anterior to the tragus of the ear. The vertical incision given. Sometimes what happens, in order to release the ankylotic chunk, you have to extend the incision. We say it as Alkire-Bramley incision. The reverse question mark incision given just in the temporal area above the pre-auricular. You have to extend the pre-auricular incision superiorly to the scalp in the reverse question mark fashion. It is known as Alkire-Bramley incision. Another variation is you can extend the pre-auricular incision like a hockey stick. It is known as hockey stick appearance is there. Just you have to extend the pre-auricular incision, but Alkire-Bramley incision is preferred, because in case of Alkire-Bramley incision, you can expose the large area, and sometimes the ankylotic chunk is very large. It's not possible to release all the ankylotic chunk through a small pre-auricular incision. So for the treatment of PMJ ankylosis, you have to give Alkire-Bramley incision. Alkire-Bramley incision is a modification of or variation of pre-auricular incision. Another thing you must remember is whenever you are replacing the ankylotic chunk with either artificial temporomandibular joint or costochondral graft, you must have to give submandibular incision as well, because you have to expose all the lateral surface of the ramus. You have to put the artificial temporomandibular joint or costochondral graft on the lateral surface of the ramus. So you have to give submandibular incision as well. And in case of submandibular incision always should be given about 2 centimeters below the lower border of the mandible in order to prevent marginal mandibular nerve paresthesia or paresis. You have to relieve the ankylotic chunk through pre-auricular incision. You have to